CRC empowered medical professionals to integrate clinical work with research for better healthcare. Our vision is to become the leading clinical research center in Asia. We vow to improve patients' health outcomes through ethical and quality clinical research. We collaborated with different experts and stakeholders to conduct research that matters to our patients. In 2010, the National CRC established the first early phase clinical trial unit in Malaysia, bridging the gap between laboratory and clinical research. CRC was recognized by the Healthcare National Key Economic Area in creating a supportive research ecosystem alongside Clinical Research Malaysia, CRM, a trusted global research management organisation established by Ministry of Health in 2012. The CRC network continued to expand with more hospitals joining the network in the past 20 years. The network of 37 hospital CRCs has become a unique landmark for Ministry of Health to advance healthcare in Malaysia. Malaysia is among the top 30 in the world and leading in Southeast Asia in terms of country readiness for global clinical trials, especially for oncology, infectious diseases and cardiology trials. The National CRC was rebranded as ICR in 2019 under the National Institutes of Health and continued to support both investigator-initiated research and industrial-sponsored studies. During the COVID-19 pandemic, Dr. Kalai Rasu led ICR to support the ministry with many impactful research and digital innovation, such as the RECOVAM study that investigated vaccine effectiveness in the real world, and COUGH-E, an AI screening application using cough sounds. ICR will continue to support IIR-ISR collaborative research capacity and infrastructure building. ICR consists of 4 research centres and 2 units. CCT focuses on early phase clinical trials and bioequivalence study that enhance treatment and outcome. CCE conducts clinical epidemiological research to generate data-driven insights that shape better clinical practice and healthcare. C-Core conducts research that evaluate and improve clinical care and outcome, particularly on infectious diseases and cardiovascular diseases. CCRN, the Secretariat for National GCP, ICR Scientific Review Board and Trainings, conducts diabetes and hypertension research. BHRI focuses on enhancing health services and outcome with cutting-edge digital technologies such as artificial intelligence. Sigma enhances research, administrative, governance and strategic planning for ICR and network. Together, Malaysia has the preferred hub for clinical trial in Asia. The Ministry of Health has achieved significant increase in research outputs and impacts to patients. Over 25 years, we never forget our purpose. We conduct research that matters to patients.
Welcome back, everyone. And to those of you just joining us today, welcome. And just a bit of a housekeeping announcement again. The link to both the Google question form and also the attendance and feedback form is available at the YouTube description box below for you to use. All right, so now let us meet our speakers for today. It is my pleasure to introduce our first speaker, Ms. Hoon Shien, on my furthest left. Ms. Tay is a research pharmacist at the Center for Clinical Epidemiology, and she is deeply passionate about transforming complex health data into actionable clinical insights. With a background in pharmacy and a master in science, she has successfully transitioned from managing clinical trials to diving deep into epidemiological research, ultimately striving to shape evidence-based public health policies that directly improve patient outcomes. And sharing the stage with her and presenting the second half of the session is Dr. Amy Hwong. Dr. Amy is a clinical epidemiologist and currently serves as the head of the Center for Clinical Epidemiology at ICR. She is also affiliated as an associate scientist with Julius Global Health, University Medical Center Utrecht in the Netherlands. With a solid background in clinical medicine, she holds both a master's and PhD degree in epidemiology from Utrecht University. Dr. Amy published in peer-reviewed journals and frequently presents her work in both local and international conferences. Her research portfolio spans clinical epidemiology area, including cardiovascular care, stroke, cancer, and palliative care. So Ms. Hoon Shien will be kicking things off for us, and Dr. Amy will then continue with the second half of the presentation. So to both Ms. and Dr. Amy, I now welcome you to begin your presentation. The screen is yours.
Good morning, audience, and welcome to our CME. Thank you, Dr. Atiqah, for the kind introduction, and to the organizers who have invited us to deliver this round of NIH CME. For this session, Dr. Amy and I will share the local evidence from the collaborative study between the Institute for Clinical Research and Hospital Sungai Buloh. So to map out the session, let us share the overview of today's presentation. We have structured it into 5 distinct parts. First, I'll go through the study background and highlight why cardiovascular disease is an important discussion among people living with HIV. Next, I'll go through the methodology, specifically on how we link the national data sets. And I'll continue with part 1 to review the actual burden of cardiovascular among people living with HIV after accounting for their competing mortality risks. In part 2, Dr. Amy will take over and to talk about the validation works of our commonly used risk models in practice and their performance. And finally, we'll discuss on the study impact on future clinical practice and research. So let us start with the global and regional context of HIV epidemic today. So there are nearly 40 million people living with HIV. While sub-Saharan Africa remains the epicenter, our region, which is the Asia Pacific, is also home to quite a large number of people living with HIV. And over the last decades, antiretroviral therapy has radically transformed this landscape, bringing down a massive drops in AIDS-related death and turning what was once a fatal diagnosis into a manageable chronic conditions. But this, at the same time, bring age-related or treatment-related comorbidities directly to our clinic door. But why is specifically cardiovascular disease and a prominent issue among this surviving cohort? So this is the crucial clinical takeaway. The global evidence show that people living with HIV have double the risk to develop cardiovascular disease compared to the general population. And this is not just because they grow older. If we look at the pathophysiology, the risk factor, the elevated risk is mainly driven by the interaction of the 3 groups of risk factor. First is from the traditional risk factor, whereby the standard cardiovascular risks such as hypertension, obesity, and dyslipidemia were highly prevalent in our clinic populations. The second contribution is actually coming from the antiretroviral therapy that they have to initiate for lifelong. And certain older drugs carry the risk to trigger metabolic syndrome, dyslipidemia, and also mitochondrial dysfunction. So the third contributing factor is from the HIV disease itself. So even with good viral suppression, we know that low-grade chronic inflammation and immune activation could always persist. And this interaction actually results in plaque formation and also premature coronary artery disease. So now knowing the risk is doubled, let's look at what the regional data projects for the next coming decade. So according to the TREATS Asian Observatory database, which is a multi-countries registry that is tracking on the HIV-specific outcomes, it is projected that the CVD incidence in Asian people living with HIV is going to double in the next 10 years. So the good news from here is that we can actually potentially mitigate the risk through CV preventive strategies such as statin prescription and maybe ART regimen modifications. But here is the challenging clinical question. How do we accurately identify people living with HIV who are at the highest risk for the preventive strategies? So from this study, we actually try to address 2 clinical gaps. First, what is the true burden of our local population. So we are trying to overcome the methodological issue by using a competing risk approach, and mainly because the standard survival analysis tend to overestimate cardiovascular risk by treating non-CV death as a simple censorings. The second gap is on the performance of those Western developed risk models in our local setting. As you know, clinical guidelines have relied on models derived from Western general cohorts, such as the well-known Framingham risk score, without local validation. So to answer these two questions, we built our foundational cohort through linkage of multiple data sources. We took the population from the Malaysian antiretroviral therapy cohort, in short it's called MATCH, from the Hospital Sungai Buloh. And for your information, Hospital Sungai Buloh is the referral center for HIV in Malaysia. And to get the specified outcomes, we then link this population cohort to the two main outcome sources, which are HDW, stands for Malaysia Health Data Warehouse, and Department of Statistics Malaysia. So in this way, we can get the first cardiovascular hospitalization or the cardiovascular related death. At the same time, we also capture a wide spectrum of composite events, which include fatal CV events and non-fatal CV events for angina, MI, heart failure, etc., as well as some major cardiac procedures. So this diagram actually illustrates the flow of the data linkage process. It's like putting the puzzles together. We took the population cohort and we fit it into the definitive outcome sources to get the full clinical picture. So to reach the objective that I mentioned earlier on, while we took the same population from a single match database, we then specifically tailor the timelines accordingly to address the clinical needs of each analysis. So for part 1, which is the epidemiological cohort, we needed a long-term follow-up. So we include all eligible patients from 2007 to 2023. So by having this large population number and also long-term follow-up, we'll be able to carry out the competing risk approach to estimate the cumulative risk of CVD among people living with HIV in the presence of their competing risk. So for part 2, which is a model validation cohort, we took a smaller but more recent subset of the database, and which spans from 2016 to 2022. So there are two practical reasons why we are doing this. First is because the match cohort has started becoming more comprehensive starting from 2016. And second reason is because we were specifically validating a 5-year risk model. So therefore, the minimum amount of observation window that we need is 5 years, which naturally kept our follow-up time till 2022, considering we took the baseline from 2016 to 2017. So the aim for part 2 is pretty straightforward. We just want to see which model performed best for the clinicians to use in their clinical practice. So now let's take a look on the key findings for the part 1, which is the epidemiological cohort. So who were our patients? Most of them were male, with a young median age of HIV diagnosis, which is 31 years old. Most of them were Malay, followed by Chinese and Indian. The main mode of transmission is homosexual contact and injecting drug user. In terms of drug treatment, most of them had exposure to NRTI, and NRTI less for protease inhibitor and integrase inhibitor, and about 20% of them were treatment naive. So overall, this is a young active population started on lifelong therapy for antiretroviral. So now let's look at the cumulative incidence of their cardiovascular event. So this is one of the important slides for today's presentation. It's called cumulative incidence function curve. And the blue line represents the cardiovascular event. The red dotted line is the death from other causes, which is their competing risk. So in total, in our cohort, there are 287 people developed cardiovascular events. Please note the upward trend of the blue line. At 5 years post-diagnosis, the cardiovascular risk reached 1.9%, which is double up to 3.8% at year 10 and reaching 7.1% by year 15. But please also note the red dotted line, in which 20% of our cohort died from other causes by year 15. So if we ignore this depth, the calculated CVD risk would be falsely elevated. But even after we account for it, the 7.1% for CVD risk at 15 years is still a substantial clinical burden. So the next question is the risk distributed equally? So we have looked into two main demographics, which are age groups and also ethnicity. On the left-hand side is the cumulative incidence curve separated by age group. Not surprisingly, age group is a major driver, whereby those patients who were above 40 at the time of diagnosis have higher incidence of cardiovascular events compared to the rest. So this suggests that among our patients, aggressive screening can be offered to those who cross the age 40 threshold. On the right-hand side, which is the cumulative incidence curve by ethnicity, the orange dotted line represents our Indian patients. We can see that after 5 years post-diagnosis, they actually the line actually separated from all other ethnicity sharply. So what this could suggest is that 5 years could be a critical inflection point, suggesting a closer cardiovascular risk assessment among these specific subgroups. So until now, I have uncovered the burden of cardiovascular disease among our people. The next logical question would be, how well do the risk models that our clinicians use in practice behave in the real world? To answer this, and to talk more about the validation work, I will now pass my presentation over to Dr. Amy.
Thank you, Ms. Tay. So good morning, everyone. So Ms. Tay has earlier on spoken about why did we conduct this study? How did we establish the retrospective cohort via data linkage using multiple data sources and our findings on the competing risk analysis to estimate the cardiovascular burden in our Malaysian people living with HIV. So moving on from that, I would like to share about the use of cardiovascular risk prediction models to estimate cardiovascular risks among people living with HIV, and specifically in Malaysia, which score are we currently using and which score are we recommending following our findings? And with that, subsequently discuss the application of our findings into clinical practice. So we know that people living with HIV has an increased risk of developing cardiovascular diseases, but this is potentially mitigated via effective preventive strategy. So the question here is, how do we accurately identify those of higher risk for us to prioritize for preventive therapy as well as management and monitoring of cardiovascular diseases? Well, the use of clinical risk prediction models has always been known to be one of the easiest, simplest, yet effective strategy for risk stratification. There are many clinical risk prediction models for cardiovascular risk estimates that's available. In fact, a systematic review has shown that in 2016 alone, there are as many as 363 models just predicting cardiovascular risk estimates. Among the more popular ones include for general population, the Framingham Risk Score, the American Heart Association Pooled Cohort Equation, or there is a revised version called the revised PCE, or the Systematic Coronary Risk Evaluation, or more known as SCORE. For the HIV population, there are also a few models that have been developed to estimate cardiovascular risk. One of the recommended ones is the data collection on adverse event of anti-HIV drugs, or more known as the DAD, and it has a full and a reduced version. One key thing that we need to understand before we apply the use of the models into our population is that the clinical risk prediction models that we rely on for cardiovascular risk estimates were not built for our own original population. So locally here in Malaysia, for the general population, we have been using FRS, which is recommended in our cardiovascular prevention guidelines in 2017. Of recent, the revised PCE is also recommended following an external validation which showed that it has better predictive performance compared to the FRS and SCORE. For our HIV population in Malaysia, the HIV consensus statement in 2022 also recommended FRS based on our CVD preventive guidelines in 2017 for general population. And this is simply because there is a lack of studies validating these models among the Asian people living with HIV. While adopting is practical, But this also shows that we are yet to conduct necessary external validation of these models in our own population. External validation is essential because it assesses potential generalizability and ensures reliability of these models in new settings such as us in Malaysia to guide accurate local clinical decisions. Hence, the objective of our study is to externally validate and compare the performance of three most common cardiovascular risk prediction models among Malaysian people living with HIV. So we included the Framingham risk score and the revised PCE for the recommendations for the general population and compared it against the HIV specific model, which is the DAD model, both the full and the reduced version. So across all these models, the variables are pretty similar, but apart from some specific ones which are tabled out here. So in terms of traditional demographic and clinical risk factors, which includes age, sex, blood pressure, active smoking, lipids, and diabetes, all these variables are included in all the models that we're comparing. The revised PCE has an extra race variable, whereas the DAD full and reduced version include family history of CVD as well as CD4 count. The only difference between the reduced and the full version is the omission of the HIV medication exposure or specific antiretroviral drugs. So out of 6,339 people living with HIV, whom we followed up over 5 years up to December 2022, 2.1% of them had a cardiovascular event. This includes both fatal and non-fatal events, primarily for stroke and myocardial infarction. Noticeable differences were observed in terms of their variables, in terms of their factors between those who developed the event compared to those who did not develop the event. In terms of age at baseline as well as ethnicity, those who developed cardiovascular event were older and there were more Indians and fewer Chinese. The use of Atiqah was also higher, and the median time from HIV exposure, HIV diagnosis was also longer amongst those who developed cardiovascular event. In terms of cardiovascular risk factors, almost half of those who developed cardiovascular event were active smokers, and about a fifth of them had family history of cardiovascular diseases. Proportions of cardiovascular risk factors, which includes diabetes, hypertension, and dyslipidemia, were all higher in those who developed cardiovascular event compared to those who did not. Now, moving on into evaluation of model performance, let me briefly explain what the few next slide would entail. So in terms of predictive performance, there are two aspects that we would usually look into. The first is discrimination, which is assessed via area under the curve or C statistics. And this is basically the model's ability to distinguish between individuals who develop the event versus those who do not. And the question that we really are trying to answer here is, between two individuals, who is more likely to have the event? The second aspect of predictive performance, which is very important but often overlooked in most of the predictive performance exercises, is calibration. This is assessed via calibration plots as well as the observed versus expected ratio. This assesses the model's agreement between the predicted risks as well as the observed outcomes. And we're answering here, does the assigned predicted risk from the models actually match our clinical reality? So let's have a look at the results from our study. In terms of discrimination, all models perform comparably. The range of C statistics range from 0.75 to 0.77. On average, about 77% of our patient pairs are correctly ranked. This shows good discrimination, which means that all models can correctly identify which patients are of higher risk. But in clinical practice, this is not it. Absolute risk, which we can get from calibration, is also necessary and is as important for us, for the clinicians to guide clinicians for good clinical decision making, as well as to choose the right interventions for our patients. Let's have a look at calibration. So this is the calibration plot, which shows that the nearer the dotted line is towards the diagonal line, the better the calibration is. So in brief, the calibration plot here shows that the general population models, which includes the FRS as well as the RPCE, the revised PCE, had systematically overestimated the cardiovascular risk of our Malaysian people living with HIV compared to the HIV-specific model, which is both the DAD full and reduced version. So combining the above estimates together, we then identified the DAD reduced model as the best fit model to estimate 5 years cardiovascular risk among Malaysian people living with HIV. And this is taking into account this discrimination, calibration, as well as the greater practical feasibility. Moving on from the predictive performance exercise, we went then on to re-stratify our patients with the DAD reduced model. So about 50% of our patients were from moderate to high or very high risk, although only less than 10% of our patients are classified as high or very high risk of developing cardiovascular diseases in the next 5 years. We found out that only less than 10% of these patients were prescribed statin during follow-up. Hence, this shows a huge opportunity to improve preventive cardiovascular care with the use of the DAD reduced model. So we've resolved the statistical validity via comparing the predictive performance of the models. But we know that also that statistical accuracy alone does not automatically translate into clinical usefulness. Hence, upon a request from our stakeholders for updating the HIV CPG, we then conducted an additional analysis called the decision curve analysis to assess if the DAD reduced model is clinically useful to guide primary preventive interventions among people living with HIV. And the intervention of interest is statin initiation. So we compared the DAD reduced risk-based statin initiation against a range of different alternative approach. Other approaches include assuming that everyone will benefit from statin, hence treat all strategy, and a treat none strategy that assumes no one will benefit from statin. Besides that, we also accounted for 2 other binary approaches where we included those above the age of 40 would benefit from statin, or those who has LDL cholesterol more than 3.0 millimole per liter would actually benefit from statin. So comparing all these strategies, we found that the DAD reduced model provides superior clinical utility at treatment decision thresholds of 2% and beyond compared to other alternative strategies. This finding shows us the value of individualized multivariable prediction compared to simple, easy, but rigid binary approaches. Using the DAD reduced model also targets the right patient for the right treatment and not just treating more patients. All in all, this is a cost-effective strategy because it maximizes the preventive therapy coverage in resource-constrained settings like ours here because we are prioritizing those who are most likely to benefit. So this is a brief summary of the key findings of our project. First, we showed a substantial clinical burden of cardiovascular diseases among Malaysian people living with HIV. The cumulative risk increased from 1.9% at 5 years to 7.1% at 15 years after their HIV diagnosis. With the incidence rate of about 5 per 1,000 per person years, this is 3-fold higher compared to our general Asian population. We also observed an earlier cardiovascular disease onset among our Malaysian people living with HIV at a median age of 47 years compared to 58 years among our local general population. Second, we found that the DAD reduced model is the best fit model to estimate 5-year cardiovascular risk among Malaysian people living with HIV compared to the general cardiovascular risk scores. We also found that it to be clinically useful because it accurately targets the right patients to ensure a highly cost-effective strategy. Apart from these key findings from our project, I would like to slightly sideline and also discuss a little about the use of antiretroviral drugs. So despite the omission of these variables from the DAD reduced model, we would like to emphasize that this does not undermine the importance of considering long-term cardiovascular risk whenever the clinicians are initiating or monitoring the use of antiretroviral drugs, especially the ones which have been linked to cardiovascular side effects, for example, protease inhibitor or abacavir. Well, the good news is this first-line treatment is shifting away towards newer, safer options such as integrase inhibitor. And because these HIV regimens have been evolving rapidly, hence adding these variables of older specific antiretroviral drugs into our static risk prediction models may hold limited long-term value. We're pleased to share that these findings have been published in international peer-reviewed journals. But more importantly, we'd like to discuss on how our findings could potentially impact on clinical practice. So if we have a look at the bottommost circle, the smallest circle, we saw an early cardiovascular risk. Our cardiovascular diseases strike nearly 10 years earlier in our Malaysian people living with HIV compared to the general population. This simply highlights that HIV management is no longer about just HIV care. Our standard HIV clinic visits may often overlook cardiovascular risks, and this is perhaps because of the overwhelmed number of patients as well as limited consultation time. Hence, the priority would always be immediate HIV management. While this is undeniably important, but this also means that more than 2/3 of our high-risk patients are actually left unprotected with preventative statins. Therefore, we feel that it is imperative to integrate cardiovascular risk assessment and screenings into our routine HIV care. And in that, we're supporting the use of the DAD reduced model as part of the cardiovascular risk assessment. In case anyone who's interested to use or to look into the DAD reduced model, it's freely available online, and you can scan the QR code here as well as look into the link that we have shown here in the infographic. So this infographic will also be available in ICR social media soon, so do watch out the space. Before we end this presentation, I'd like to take some time to actually extend our gratitude and recognize the dedication of our team members behind the work. So first and foremost, our Director of ICR, Ms. Karen Tay, for her help and support throughout this project. Next, our infectious disease clinicians in Hospital Sungai Buloh, Dr. Tay Kim Heng, who's also the co-PI of this project, Dr. Lee Jie Ling, Dr. Sailesh, as well as Dr. Ben Sim. From the Institute for Clinical Research, apart from myself and Ms. Tay, Dr. Yvonne Lim and Ms. Yang Sulan has also contributed heavily towards the project's success. Special thanks also go to our dedicated research assistants who spend months collecting data for us, as well as our colleagues from CRC Sungai Buloh, colleagues from Sector Biostatistics and Data Repository NIH, Jabatan Pendaftaran Negara, Department of Statistics Malaysia, and last but not least, our colleagues from Malaysian Health Data Warehouse from Bahagian Perancangan, Ministry of Health. With that, I thank you. And now I'd like to pass it back to our moderator, Dr. Atiqah.
All right. So thank you so much to both Ms. Tay and Dr. Amy for that incredibly insightful data-driven presentation. It is actually truly eye-opening to see how our own local data can reshape the way we approach cardiovascular prediction and care in Malaysia. So now we will move straight to our Q&A session. I see that our live audience has actually been pretty active and there are several questions already lined up for us. So if both speakers are ready, we'll begin right away. All right. Okay. So to start things off, maybe the first question to Ms. Tay. From a viewer who is interested about your study design in part 1. The question is, when looking at the design of your study, you chose a competing risk approach, as you've mentioned, for the long-term 15-year data. So how does this method change the way we look at our patients' data as compared to the standard survival charts that we usually see in the medical journals?
Right. Thank you for the questions. So standard survival analysis usually just look at the primary event and treating death from other causes as censored data, as if the patient just dropped out from the study. But in reality, a patient who has died is no longer at the at-risk pool for primary event. So by using this competing risk approach, we actually account for these mutually exclusive endpoints. And by adjusting the risk set accordingly, we can give a true estimates of the clinical risk. But having said that, this approach is actually highly recommended for long-term study like ours, because over extended time frame, it is logical that patients do die from other causes other than the primary event.
All right. Thank you, Ms. Tay. And moving from the statistical model to our current everyday practice, this next question is for Dr. Amy. The viewer asked, we know that the Framingham risk score, as we mentioned, is already widely used and it's embedded in our consensus statements. So what are then the clinical implications if, let's say, our Malaysian clinicians continue to rely on this for PLHIV?
Yeah. Thank you for the question. So as of now, the current consensus statement still recommends the FRS, but we all know from the research findings that the FRS overestimates risk, and overestimates risk would mean that there'll be unnecessary overtreatment, especially in our lower risk population. I think in settings like ours where resources are available but constrained to a certain extent, the priority would be to have a tool to guide our clinicians to target the right patients for the right treatment. And therefore, the intervention, such as prescription of statins, would then be clinically justified as well as in terms of practicality will be cost effective as well.
Right, understand. Well, thank you, Dr. Amy. Now, following up on that question and going to the clinical version, for Dr. Amy, a viewer has noted that you have mentioned 70% of the high-risk patients in this cohort were actually not prescribed statins for their primary prevention in our local setting. So what do you think could have potentially led to this, and if so, how could we address it?
Yeah. Thank you. So I think there are two aspects of this. So the overestimation of risk as well as the underprescription are two separate methods. Overestimation of risk belongs to the aspects of statistical validity, whereas the underprescription belongs to the aspects of clinical practice. We did not conduct a subsequent study to look into the reasons for underprescription, but I think generally the outpatient clinics have huge number of patients, lack of a shortage of clinicians with very limited consultation time. So in that sense, the priority would always be the immediate HIV management. While this is undeniably really important, but consequently, I think chronic comorbidities such as cardiovascular diseases would be inadvertently sidelined. So I think to address this, it's really important for us to see how we can integrate cardiovascular screening and risk assessments into our routine HIV care. It's easier said than done, and because implementation is not as easy as us saying it. So I think the implementation work itself goes beyond just our research findings.
Yeah, I think just to add on what
Yes,
Dr. Amy had just said, I think implementation is challenging for sure. But I think one of the practical solutions that we can think about is how can we embed the risk calculator into electronic health records in the future, and perhaps transitioning those stable HIV patients to primary care clinic.
Right, so that's probably one of the way
Yeah,
forward maybe that we
yeah,
can think
correct.
of. Right, all right, okay, thank you. So now the next question from the audience is looking at the big picture. This one, I'd love to hear your thoughts on this, Ms. Tay. A viewer has asked, like, when we look at the big picture that you've shared earlier, it feels like the role of a HIV clinician is changing actually. So how then should we adjust our mindsets for when a patient comes into our clinic tomorrow?
Right. Thank you for the question. Yes, the main message that we are trying to deliver here is actually to move away from looking at HIV just an infectious disease alone. So perhaps treating it as a cardiovascular risk factor could be the first step, just like how we see hypertension and diabetes. And if a patient walks into your clinics tomorrow, taking care of their viral load still the gold standard, but it's only half of the story. So taking care of their risk factor is actually equally as important as controlling the virus, so that they don't come back to our healthcare system as another disease.
Right. Okay. I think we have time for one more question. Let's look at the questions for more that we have. And this one is actually quite practical question, I would say. For those clinicians who are looking to apply your findings for their own setting. Dr. Amy, perhaps for this one, where can I actually find this DAD reduce calculator, and whether it's free for all the Malaysian clinicians to use?
Yeah, so actually it's freely available thanks to the developer. It's also available online, just that perhaps it's not easily searchable via Google. So hence, by getting the permission from the developer, we have been receiving the permission to actually actively promote it. So we've created an infographic which we have disseminated to our local ID clinicians, and it will also be up in our ICR social media soon. So do watch out the ICR infographics for you to get the QR code as well as the link to the DAD Reduce tool.
Right. So just to recap back, the DAD tool can be found at the website based on the QR code.
Yes.
Right.
Yeah.
Okay. So that's for the audience who are interested. So I think, all right, that's all the time that we have for questions for today. Thank you so much to our live audience for those engaging questions, and also thank you to both our speakers for providing a clear, thorough, and practical answers. So if I may summarize a bit from our session today, just probably a key take home from what I personally also learned from today's session is that based on our local data, it seems like it's a very powerful reminder that our management for PLHIV should no longer just be about HIV care alone, and that we should take into consideration the long-term cardiovascular risk as a core consideration, especially when you want to initiate or monitor the antiretroviral therapy.
Correct.
Right. All right. Okay. Okay, all right. So as we wrap up today's session, I would like to again extend our heartfelt gratitude to Mr. Hoon Shien and also Dr. Amy Hwong for generously sharing their time, expertise, and brilliant research findings with us today. And on behalf of the organizing team, we would also like to sincerely thank all our participants for taking the time out of your busy morning to join us. We truly hope the CME has provided you with valuable insights that you can translate back into your respective clinical practices. So with that, we officially conclude today's CME. Thank you once again, stay safe, and have a pleasant day ahead. Bye-bye.